The first intensive care was established in Sweden in 1950, but pediatric intensive care as a distinct subspecialty is only 20 years old. But what has changed since then? Patients with chronic and complex problems who would otherwise have not been admitted to intensive care or offered treatment, patients who would not have who would have died now survive because of change in infrastructure, expertise, training, and centralization of ICU resources. Starting with your ABCs, your ILCOR CPR guidelines, there is now emphasis on your C for chest compressions for patients without pulse, but we all know that children are more prone for hypoxia, and therefore A and B has to follow very soon. It may be reasonable to start with chest compressions because bystanders are wary and squeamish about giving mouth-to-mouth, may not know how to give mouth-to-mouth. Both cuff and uncuffed tracheal tubes are acceptable in children, but one has to monitor cuff pressures. Avoid excessive ventilation in infants and children during resuscitation to avoid cerebral ischemia and hypocapnia. And the sequence now is CPR followed by one shock and then CPR. The code blue is now a thing of the past. After the introduction of the rapid response team or the medical emergency team, there has been a steady decline in the incidence of cardiopulmonary arrest in the wards. What if there was a tool to detect, for the sisters to detect warning signs and differentiate between well and sick children in the ward? And this is the bedside early warning system, the Pew score, very simple variables with sisters anyway monitor. It's a score from 0 to 26. Simulation in pediatric critical care, there's an explosion of simulation. After the initial investment, which is quite high, is quite useful because there's limitless opportunity to go wrong and it offers corrective feedback. This is low fidelity simulation, mock codes in the ward, and you can see in the study the survival following cardiopulmonary arrest improved by 50% after randomly conducting mock codes in the wards. Coming to airway, placement of an endotracheal tube prolongs ventilation, need for sedation, hospital stay, cost goes up, and so the pendulum is swinging now towards early tracheostomy to liberate children from mechanical ventilation. Non-invasive ventilation, very popular both in adults and pediatrics. We have now this new interface, helmet-delivered CPAP, and for NIV2. This is a pilot study which showed that there was less leak with this modality. Heliox can be used in upper airway obstruction as well as moderate asthma. High-frequency ventilation is a popular, safe, and effective means of ventilating patients with ARDS. And this was a meta-analysis done last year which showed both adult and pediatric studies, which showed that the PF ratio was better in patients with high-frequency oscillation, and so was the survival. Surfactant therapy for acute respiratory failure. This study, this is a meta-analysis which excluded neonates. The mortality was less in patients who received surfactant, so was the ventilator-free days and duration of ventilation. Balanced concept of fluid resuscitation. The use of isotonic fluid as maintenance therapy prevents iatrogenic hyponatremia. And this is a study which showed, randomized study which showed that patients who received hypotonic fluid as maintenance had more hyponatremia in the first 24 hours of admission. So much so that even for gastroenteritis, the WHO has changed from half GNS to oringalactate as replacement fluid, because critically ill patients, even with gastroenteritis and low urinary sodium, still have high urinary sodium loss, low serum sodium. This is the Association of Pediatric Anesthetists guidelines for perioperative fluid management in children, and they recommend only isotonic fluid, that is intra-op and post-op. So much so that the National Patient Safety Alert guidelines in UK has removed 1/5 saline from general stock, and you need a separate protocol to dispense it in certain situations. And this is the Cochrane database and archives consensus that only isotonic or near isotonic fluids are safer in critically ill patients, children, and also in the perioperative period, because the risk of hyponatremia is 17 times with the use of hypotonic fluid. What about resuscitation? This is what Rivers had to say. There are important benefits to the goal-directed administration and removal of fluid during appropriate phases. In contrast to what is true in politics, in fluid management, it is okay to be both liberal and conservative, which means that in early goal-directed therapy, you have aggressive fluid resuscitation, and once the patient is resuscitated out of shock, that's when you have aggressive fluid removal. And this study came in critical care medicine this year. Fluid resuscitation in septic shock, a positive fluid balance on day 4 was associated with increased mortality. There are similar studies in children too. This is in stem cell transplantation. A less than 10% fluid overload was associated with better survival and less requirement for ventilation. But it's really hard to know when is the transition from shocky phase, from the time you read the fluids, to the phase when you have to dry your patients out. Temperature. Patients who had arrest, pediatric patients, in the first 24 hours after arrest had persistent hypothermia, and this was associated with an unfavorable neurological outcome and death, even after controlling for potential confounding factors. And so it is, as per the ILCOR guidelines, it's okay to cool them for the first 24 hours. But this study, this is a Canadian trials group, moderate hypothermia after traumatic brain injury in children, showed that in children with severe traumatic brain injury, hypothermia therapy that is initiated within 8 hours of the injury, the temperature here was 32 to 33 degrees, and continued for 24 hours did not improve the neurological outcome and may increase mortality. In perinatal asphyxia, here there was no change in death or disability, but there was better neurological outcomes in survivors. Decompressive craniectomy, as we all know, is now part of your treatment, your 2-tier algorithm for refractory intracranial pressures. New modality of treatment in burn, oxandrolone, both in pediatric and adult patients, can be given in the initial phase, that is after your capillary leak, as well as in your rehab. What does it do? It improves your protein synthesis, muscle strength, promotes weight gain, serum protein concentration. And there are studies use of recombinant antithrombin. In adults, there have been studies with the use of beta blockers to reduce hypercatabolism and the heart rate. What are the other drugs? Intravenous levetiracetam. It has got multiple modes of action. It has no drug interactions, not protein bound, is very few side effects, doesn't involve your hepatic metabolism. And there are, though the studies, FDA has approved it only above 16 years, the IV form, and oral form above 4 years. There are many studies with its use even in infants, so much so that it's part of your status epilepticus algorithm now. This is the Neurology 2008 and Journal of Intensive Care 2007. So you can see levetiracetam comes soon after fosphenytoin for persistent seizures because it does not have respiratory depression, so even before phenobarbital. Sedation in intensive care is quite a challenge. You want your child sleepy enough so not to self-extubate and injure oneself, but also light enough to have short weaning times. So it's not really possible to do your spontaneous breathing trial and spontaneous awakening trial in pediatric patients on a daily basis. So they tend to be for a prolonged period on opioids and benzodiazepines, and so can have more withdrawal. And this is the first withdrawal assessment tool from Netherlands, and you can see these are we would have seen our patients with these withdrawal signs, watery stools, startling to touch, tremors, etc. The maximum score is about 12, and a score above 3 was associated with longer opioid weaning period, longer length of mechanical ventilation, PICU, and hospital stay. Children also can have delusional memories, and this was associated with prolonged opioids and benzodiazepine use. So what is the solution? This is the new sexy drug which everybody is talking about, dexmedetomidine, quite a mouthful. What does it do? It's an alpha-2 agonist like clonidine. It causes calm and cooperative sedation with easy arousability, no respiratory depression, but it can cause bradycardia and hypotension. Though the recommendation is only for use for 24 hours. There are a lot of studies with use for much more prolonged periods. This study for about 110 hours. Another one, median age was 36 months, and the average length of use was maximum 60 hours. But it helped reduce the need for other sedation medications. In pediatric cardiac intensive care, quite safe. and also in non-invasive ventilation because it doesn't cause respiratory depression. What are the drugs for the heart? Levosimendan, it's a calcium sensitizer, ionodilator, and has lucitropic effect. This is a study this year which showed rotating inotropic therapy, that is 1 week of Derbute, 1 week of Milrinone, and once a week levosimendan, because the half-life of it lasts for a week. Insulin therapy in pediatric intensive care. This showed that with intensive insulin therapy, the mortality and PICU stay was less, but there was more incidence of hypoglycemia. This is a very important revised consensus guidelines for treatment of DKA patients. Only isotonic fluids are advised in the first 12 to 24 hours of DKA management to prevent drop in serum osmolarity. And also for the same reason, in insulin, they have advised delay in the introduction of insulin infusion for the first 1 to 2 hours. Blood transfusions are expensive, unnecessary, and quite unsafe, because this study showed that it was associated with longer days of mechanical ventilation, PICU stay, mortality. And so, like in adults, we adopt a restrictive transfusion protocol, a transfusion threshold of only 7 in stable critically ill children. Are red cell transfusions associated with nosocomial infections? Yes. In the study, the odds ratio was 3.72. Central line associated bloodstream infections also associated with more RBC transfusions. There is more risk of healthcare-associated infections. This was the only study which compared all the 3 blood products, RBC, platelets, and FFP, and this showed that with the use of FFP, there was higher mortality, and every mil per kilo of FFP transfused, the odds ratio was 1 for mortality. This study from adults, but I thought I would have to share it with pediatric. We always check urine output, never bowels. And our patients can be constipated because of ileus, and that can cause bacterial overgrowth and nosocomial infection. Scores, we have the rifle criteria, pediatric rifle. In adults, they use the serum creatinine and GFR. In children, it is the estimated creatinine clearance. A new score, DIC score, using simple variables, platelet count, fibrinogen, prolonged PT. A score more than 5 was associated with mortality, 5 on 8. Is the canary still singing? This term is... Miners in the past used to take canaries when they didn't have sophisticated gadgets to detect poisonous fumes, and the canary would stop singing and drop dead if they did detect a gas. And so this phrase, is the canary still singing, is used to denote a warning for something ominous. And in our ICU, the canary is the bladder pressure, because it can detect abdominal compartment syndrome, which has a mortality of 50%. And this is the intravesical pressure of more than 15 with 2 or new organ dysfunction is abdominal compartment syndrome. The volume of saline advised is 1 ml per kilo, maximum 25 mils. And you know the treatment. New cause of multiple organ dysfunction, HLH, suspected when a patient has fever, pancytopenia, splenomegaly, and a very, very high ferritin. Ultrasound has now been embraced by both critical care physicians and emergency physicians for not only for the traditional uses, for optic nerve head, for intracranial pressure, detecting pneumothorax, lumbar puncture, etc. We have a lot of superbugs with no drugs, a lot of community-acquired MRSA. We all know we have to hit hard, hit fast with broad-spectrum antibiotics and de-escalate. This is a new this has been started by the Global Pediatric Sepsis Initiative, a new website which anybody can access. It has interactive tutorials, guidelines, etc. Like adults, we also bundle up our patients. This study I just wanted to share with you to emphasize the importance of surface cleaning. This was done in 27 intensive care units, came in critical care. This is in 36 hospitals. Use of fluorescent gel to assess thoroughness of environmental cleaning. So it was applied in all high-risk objects, your bathroom doors, computer mouse, and this is before this there was slipshod cleaning, and afterwards quite vigorous for fear of detection. Last but not least, communication in the PICU. This is the HIC. Be honest, include your parents, patient's family, be compassionate, clear, comprehensive, and coordinate all your specialities. So what is the vision for the 21st century physician? It is the most cost-effective opportunity will likely come not from discovering new therapies, from discovering how to deliver therapies that are known to be effective. I finished. My last slide. I think this is the era of less is more. We seem to be giving less of ventilation during CPR, less of ventilation for raised ICP, less of transfusions, less fluid during resuscitative sepsis, less sedation, less steroids, less days of antibiotics, but definitely not less time with our patients. Thank you.